Good evening, everybody. Tonight we will be discussing some of the infectious agents that also can be transmitted sexually. And we will start talking about herpes virus or herpes viruses in general. Then we'll talk about the human papilloma virus, and then molluscum contagiosum virus. And so the herpes viruses belongs to a family. We call them the herpes viridae. They are composed of large enveloped viruses. They are double-stranded DNA viruses. This is really very important to know. There are 8 known human herpes viruses. We call them herpes human viruses type 1, 2, 3, up to 8, and a very large number of animal herpes viruses. The human herpes viruses, they include the herpes simplex virus, which is type 1 and 2, which causes facial and genital lesions. Then we have the varicella zoster virus, which causes the disease. We call it chicken pox, and later in life can be reactivated to cause a disease. We call it shingles. Then we have the Epstein-Barr virus, an infectious cause of mononucleosis, as well as a tumor. We call it Burkitt's lymphoma, among other B-cell lymphomas. So it's an oncovirus. Also, we have the cytomegalovirus, CMV, can also cause mononucleosis symptoms in adults, and is a leading cause of congenital blindness. This is really very important to know. Human herpes virus type 6 and type 7, we call it the human herpes virus 6 and the human herpes virus type 7, which causes a disease. We call it roseola infantum and Kaposi's sarcoma, where this is very common, as we said, with a AIDS virus. It is associated, Kaposi's sarcoma, associated herpes virus, Kaposi's sarcoma, herpes virus, also known as the HHV8, and you can look it up here. In addition, here the simian herpes viruses, herpes virus type 8, has occasionally caused lethal human disease in primates, causing here workers. Also, herpes viruses establish lifelong latent types of infections in their host, with periodic reactivation events. So it's very important to know that these herpes viruses can cause an acute type of an infection, usually affecting the skin, and then it goes and hide in the central nervous system, and then a reactivation process is going to follow. So we are going to have a recurrence of these types of infections. So those are, this table shows a summary of all of the herpes viruses, 1, 2, 3, 4, 5, 6, 7, and 8. Remember that all of them are double-stranded DNA viruses that are enveloped. So you should know those viruses and the diseases that are associated with, mode of transmission, and also the reactivation process, where the latency is going to take place, and then after that, here what are the factors that will influence this reactivation process, and then we will be talking about how to make the diagnosis, following, of course, the clinical presentation, and then treatment and prevention process. So remember that we have 8 herpes viruses, human herpes viruses from 1 to 8. Each one here has a different name that you should know all of those by heart. So the human herpes viruses, they are large than viruses, and they are enveloped, double-stranded DNA that usually they infect cells, mainly they are present in the nucleus, and within the nucleus they end up forming what we call an inclusion bodies. So remember that they are double-stranded DNA viruses that they replicate in the nucleus. Very important to know the specific event for each of those viruses, the replication cycle, and what's specific about those replication cycles, and then how we can interfere with this replication. What is or what are the things that are so specific for these viruses that we can utilize the antiviral drugs to interfere with their replication. So it's very important then to know that the herpes simplex virus, we have 2 types, type 1 and type 2. Usually they do infect the skin and the epithelial layer of the skin, usually the gingivostomatitis, and causing vesicular lesions, vesicles, and then pustules, and then ulcerations. So they occur, very important to remember, of the mouth, the lips here, gingivostomatitis, or the genital ulcers or genital lesions, genital vesicles, pustules, and ulcers that are extremely here painful. Very important point to remember that these herpes viruses, we say that when you get them, it's so difficult to forget them because they stay in our body for a longer period of time, and then we are going to have a recurrence. So the oral cavity as well as the genital area, and they can be associated with latency, and they hide in the sacral nerve root ganglia in here, or in the oral cavity here the trigeminal nerve root ganglia, and then a recurrence is going to take place. So very important then to remember about herpes viruses, herpes simplex virus type 1 and type 2. Type 1 is usually cause lesions above the waist, and type 2 cause lesions below the waist following sexual intercourse, as I said, causing vesicles and then pustules. They coalesce together and cause ulcers, and these are usually very painful ulcers. Then they go and hide somewhere in the CNS, and then later they will be reactivated. They come back again and cause the same lesions. That's why when you get those, it is so difficult to get rid of those. So herpes simplex virus type 1 and herpes simplex virus type 2, skin lesions, oral as well as genital vesicles, pustules, and ulcers, very painful ulcers, and hide or cause latency in the trigeminal nerve root ganglia, and in type 2 usually the sacral nerve root ganglia, and stay for a longer period of time. So those viruses, they belong then, the herpes simplex virus, to the herpes viridae family. They are enveloped, double-stranded DNA viruses. They are associated with skin ulcers. Then we have others, they cause chicken pox, and also they could be associated with encephalitis, and also very important sometimes malignancies like Kaposi's sarcomas as well. So herpes simplex virus type 1 and 2, and then we have the varicella zoster virus, and then cytomegalovirus, and then the Epstein-Barr virus, and then the human herpes virus type 6, 7, and 8. We have others that they could infect monkeys, like the simian herpes viruses, and they don't infect human. And we have also one we call it the herpes B virus. We have all of them, they do have a similar morphology and size. Almost their size is in the range of 180 to 200 nanometers in diameter. They have an icosahedral type of capsid symmetry, and or what we call capsid tegument. They do have what we call replication enzymes that are so specific for these viruses. So if you have drugs that can interfere with these enzymes, you can interfere with the replication cycle of these herpes viruses. The very important point also to remember that the envelope, these are envelope viruses, the envelope, it comes from the nuclear membrane of the cell. Usually we do antigenic analysis. Is usually a mean of differentiation. So we differentiate those based on their antigenic differences. So the human herpes simplex virus, remember those, type 1 and 2. Then the varicella zoster virus, those we call them the alpha viruses. Then we have the cytomegalovirus and the human herpes virus type 6 and 7. Those we call them the beta viruses. And then we have the Epstein-Barr virus and the human herpes virus type 8. Those we call them the gamma viruses. So this is a different type of classification of herpes viruses. Only they infect humans, as I said, and they infect what we call human diploid cell lines, so we can use those for culture. Very important to remember that they are associated with latency, so they can stay in our body for a longer period of time. So it's extremely important to understand the replication cycle of these herpes viruses. They bind into a specific receptor on the cell, enter, and then they multiply in the nucleus, and they code for 3 different types of proteins. So they are associated with 3 types of messenger RNAs, the ones that we call the early or the immediate genes that they will code for early types of transcription, messenger RNA, and then the early, and then the late. So immediate, early, and late. And each of those, they code for specific types of antigens that they do have a specific function. So in the immediate early, they will code for the enzymes that are needed for the replication, the immediate early, and then the early. So they code for the replication enzymes and that are needed to replicate the double-stranded DNA, and then the late proteins or the late messenger RNA that we will code for the structural proteins of the virus. So these are extremely important to know, the immediate early, and late replication cycle, and here if you could interfere with those enzymes that are specific for the DNA replication for the virus, not the cell, then we can selectively interfere with the replication of these herpes viruses. So it's so important to understand this fact here when we talk about treatment for these types of viruses. So here again, when we talk about the replication cycle that you should know, they start here by causing a lytic cycle, lytic cells in the epithelial cells that's associated with vesicles, pustules, and ulcers here. And then later they will go to the central nervous system and cause what we call latency. So they start with an epithelial type of infection that causes the vesicles, pustules, and then the ulcers, and then later they hide in the CNS. Also they attach here on the cell surface to what we call a heparan sulfate location, and then they penetrate, and then they will go to the nucleus, and within the nucleus they will circularize over there, stay, and then they form 3 types of messenger RNAs are going to be made. As I said, the immediate early, and the early, and the late. The immediate early here they code they code for what we call the alpha early transcription proteins, and then the early they cause for the early messenger RNAs or the beta genes, and those are so important for the DNA. We call it the DNA binding protein, and responsible for the DNA polymerase here synthesis that forms what we call the thymidine kinase. So the thymidine kinase is a specific enzyme for the DNA replication for the virus. And this is the enzyme that is selective for the drug that we call a cyclovir. So here when we use the antiviral therapy, the cyclovir, it targets this enzyme, which is the thymidine kinase, that's responsible specifically for the replication of the virus. Then we have the late messenger RNA, causes here what we call the gamma genes. And the gamma genes, they will code for the structural here capsid and envelopes proteins, structural proteins. So the late proteins, here we call them the precapsid. Usually they assemble in the nucleus, and then they buds from the nuclear membrane. So when they go through the nuclear membrane, they will take a piece of the nuclear membrane to form the envelope of the virus. These herpes viruses are associated with what we call a cell shutdown, and they cause death. Except the cytomegalovirus, where the cytomegalovirus, they cause activation and enlargement of the cell, while the others are associated with lysis and death of the cell. So the herpes simplex virus, we have two of those, herpes simplex virus type 1 and herpes simplex virus type 2. They do have 50% homology in their DNA sequence. They are double-stranded linear DNA genome, and they infect humans only, and the mode of transmission is through direct contact, and the infected secretions as well. Human herpes simplex virus has 10%, almost 20% of seropositives. So they form an antibody response, and most people, they do have antibodies against type 1 at least, indicating here high rate of infectivity. Herpes simplex virus type 2, usually associated with early, before puberty, here rarely associated with infections before puberty. So this virus is associated with sexual intercourse, and associated with what we call sexual promiscuity. We mean by that having more than one sex partner. 15 to 30%. So again, the herpes simplex virus type 1 and 2, they have 50% here of their genome that are alike, and 50% homology, and both they have double-stranded DNA genome. They infect, as I said, humans only, and usually the mode of transmission is by direct contact and by infected secretions. Human herpes simplex virus type 1, usually they show around 20% seropositivity. That means if you screen people all over the world, you will see around 20% of those people, they do have antibodies against herpes simplex virus type 1. Herpes simplex virus type 2, rarely, they infect people before puberty because it's usually transmitted by sexual intercourse, especially here with here prostitution or having more than one sex partner. 15 to 30% here usually they show seropositive in adults, and almost 1/4 of the population in Europe, the United States, they have a seroconversion here against herpes simplex virus type 2. Some they are asymptomatic. Some people they don't show any signs and symptoms, and sometimes they do have infection to the cervix, and the urinary bladder can be affected as well. So herpes simplex virus type 2 are the best known herpes virus, given their frequency of an infection and propensity to cause recurrent vesicles and ulceration in areas of the skin and mucous membranes. These viruses can cause progressive tissue in immune compromised persons, and they can cause encephalitis in normal hosts. Infections acquired by infants during or shortly after birth can be here respectively devastating. The two types they differ somewhat in their predilection for causing lesions above the waist in herpes simplex virus type 1 or below the waist in herpes simplex virus type 2. This is really very important to know. As with all herpes viruses, they persist in a latency, on a latent format, and reactivate to cause viral excretion and or disease. So they start with infection to the skin, and then they hide usually in the central nervous system, and then they can cause a recurrence again. So simply the pathogenesis of these herpes simplex viruses. First, they are associated with an acute infection. They can cause lysis, then latency. So skin lesions, and then latency, and then recurrence after that. And usually they affect, they are associated with multinucleated giant cells formation in the pathology, and they cause what we call ballooning degeneration of the tissue, and then they can cause what we call focal necrosis, followed by polymorphonuclear leukocytes infiltration into the area, and then they will cause sensory and autonomic. They can cause into the autonomic and nervous system, nerve root ganglia, and over there they will be associated with what we call latency. And sometimes they can go from one cell to another, cell to cell transfer to exposure, so they will not be exposed to antibodies to be neutralized. The latent types of infections, they can prove that by what we call the co-cultivation technique of the trigeminal nerve root ganglia, trigeminal superior cervical or vagal here nerve root ganglia. And then in genital herpes, usually the sacral S2 and S3 nerve root ganglia. This is the site of latency of the ones that are the type 2 or the ones that transmitted sexually. DNA usually they circularize in the nucleus, so when they do that, there will be no early or late protein synthesis will take place. So here when we use the drug like a cyclovir, it doesn't work. That's so in latency, drugs against anti-herpes viruses, they do not work. So this is the pathology. You can see the enlargement of cells. We call that the ballooning degeneration here in pathology, and this is almost pathognomonic for herpes viruses infection when we see that in pathology. So those viruses, in order to be reactivated, usually they must have certain factors that they are going to reactivate them. So one of the theories we call it the ganglionic theory and the skin triggering theory. So sometimes the skin triggering, certain stimulation of the skin can trigger the nerve root ganglia to be reactivated and to produce the recurrence. And here the host factors can be associated here with recurrence. So the ganglionic theory or the skin triggering theory, those are the ones that are responsible for the recurrence episode. Usually cell-mediated immunity and humoral immune response are so important here for defense against herpes viruses, and the antibodies that will develop, we call them neutralizing antibodies that they can provide protection. Also, we do have here the immune mechanism that we call ADCC, or antibody-dependent cellular cytotoxicity. Here usually the ADCC will limit the early spread of the virus. If the patient is immune compromised, then here it's going to make the infection so severe and associated with very high mortality rate. So the clinical manifestations then of the herpes simplex virus type 1, usually the lesions will take place, as I said, above the waist. Type 2 is usually below the waist. And it starts with a single vesicular lesions, and then after that the vesicle becomes pustular, and then those they will coalesce together to form then ulcers. And usually this is on the ectoderm. So the ulcers usually they are so painful. those patients, they will develop what we call gingivostomatitis in the oral cavity. Then latency is going to take place, and the latency is usually in the trigeminal nerve root ganglia. Another name for those are the cold sores, or we call them fever blisters, and can be transmitted by saliva. You can isolate them from the saliva. And another lesion here, usually affecting the skin, we call it the herpetic whitlow around the nail buds that can cause inflammation. So herpetic whitlow is another form of herpes simplex virus type 1 that is affecting the skin. So here you can see the gingivostomatitis. This is the skin lesions between the mucous membranes and the skin. Here where you can see the vesicles, and then the pustules, and then the ulcers that will be associated with that. These are also the same pictures of what we were talking about, gingivostomatitis affecting the gingiva and the gums in general. And you can see the herpetic whitlow. Here the nail buds could be infected. These are the vesicles at the here gingivostomatitis lesions. And then you can see that they will develop into pustules, and then they will coalesce together to form an ulcers. Very painful also the herpetic whitlow of the nail beds. So these are the different clinical presentations that we could see with herpes simplex virus. Sometimes the eyes can be infected, and keratoconjunctivitis, so the eyes could be infected and could lead to blindness here, especially if the patient is using steroids, because steroids they are immune suppressive, and so these herpes viruses cause severe infection to the eyes. So keratoconjunctivitis that could lead to blindness. Also, more severe types of clinical condition could be associated. The encephalitis here, and the temporal lobe is usually the one that is most likely to be infected. And you can here isolate the virus and identify it by the PCR, polymerase chain reaction, from the CSF. And we could use the cyclovir here for treatment. The herpes simplex virus type 2, usually this affects anatomical areas below the waist, and this is the one that is the most sexually transmitted. So it's a sexually transmitted disease then. As of herpes simplex virus type 1, we have about 90% here. Usually it's asymptomatic. And the primary lesions starts with following an incubation period of usually 5 days, followed by a papule, and then into vesicle, and then pustule, and then those they coalesce together to form ulcers. And sometimes the cervix could be infected, or even the urethra here. And some they will develop aseptic here meningitis, and this is really very, very important to know. The recurrence here that occurs with herpes simplex virus type 1 is usually followed by or preceded by prodromal types of symptoms. It starts with paresthesia, numbness here in the area, and then symptomatic, asymptomatic, and then followed by symptoms in 1/3 of patients. And then recurrence is going to take place, and the attacks from the dorsal nerve root ganglia, usually the recurrence will take place. The neonatal herpes is extremely important to know that if the mother is infected with herpes, so the baby could be infected with what we call neonatal herpes. And the baby usually is infected during delivery, especially if the mother is actively infected. The first time, and the mortality rate in those usually is high, is over 50%, especially if they develop here encephalitis, as I said. The sequence is usually bad if the CNS is involved. And as I said, the liver and the suprarenal glands, they could be infected in those types of infections. So here, when you look into the herpes simplex virus type 2, you can see the involvement of here the genital organs, the shaft of the penis, the glans penis as well, and the same thing for the vulva, the vagina, and vesicles, and associated with ulcers at the same time that are extremely painful. Very important here lesions to know. If you see them, you will never forget them because of the severe pain that is associated with such types of an infection. Recurrence, vesicles, and then ulcerations, and then recurrence after that. So if you get them, you will never forget them. So the diagnosis of these types of infections of viruses is by tissue culture and by usually monoclonal antibodies developed for diagnosis. And we could use intranuclear, could see that intranuclear inclusion bodies, and multinucleated giant cells. This is almost pathognomonic, and the smear here, we call it the Zank test, multinucleated giant cells. And you can show that by what we call pap smear here, and you stain that with Gemza stain. Also, we could use ELISA, the enzyme-linked immune sorbent assay, to detect the virus, or an immunofluorescent antibodies, or an antigens, direct immunofluorescence, or simply by PCR, polymerase chain reaction. The very important point to remember that serology as such should never here be used to make a diagnosis, because in recurrence there will be no changes in titer. Usually in serology we depend on what we call four-fold increase in titer, but if it is just single positive and there is no increase in titer, so we cannot depend on that for diagnosis. So it's used only for asymptomatic patients. The PCR is the best here for encephalitis, to make a diagnosis of encephalitis caused by herpes viruses. The drug of choice that we use for treatment is a drug called a cyclovir. And the acyclovir is a nucleotide here analog. And usually this drug is phosphorylated by an enzyme we call it thymidine kinase. Then it will change into the triphosphate form. Then this triphosphate form is going to inhibit the DNA polymerase enzyme, and then specific for the virus, and then stop the replication of the virus. So this drug, the acyclovir, is usually suppresses the recurrences and helps really in the treatment of herpes viruses. Another drug that we could use for if the patient is having acyclovir resistance, we call it foscarnet. So foscarnet is the drug of choice that we use for acyclovir resistance. Also, we have other drugs that are very effective, like the valacyclovir and the famciclovir and the penciclovir as well. All of those are very effective, and they are new drugs. Also, when we talk about the prevention, like in all sexually transmitted disease, is usually to control the sexual promiscuity. That means having more than one sex partner. We mean by that prostitution. Very important point to remember, that if the mother here is infected and we want to protect the baby, then the mother can give birth by cesarean section. Also, now they are working on a vaccine. They say that it's very, very effective. It's a glycoprotein. It's a glycoprotein. We call it a glycoprotein D for herpes simplex virus type 2. They believe that it is very effective. What about the cytomegalovirus? From its name, cytomegalo, it makes the cells enlarge. It's has the largest genome, similar to herpes simplex virus. So it is a herpes virus. It is associated with intranuclear inclusion bodies that will look like the owl eye cells. The owl eyes, we mean by that the العين البومة. Almost this is pathognomonic for the cytomegalovirus. Also, it is associated with what we call perinuclear or cytoplasmic inclusions and enlargement of the cells. So the cells usually they are enlarged. That's why we call it cytomegalo, enlargement of cells. This is what we call cytomegaly. There is no skin lesions, but latency is going to take place, so it lasts for a longer period of time. It is associated with mononucleosis-like syndrome, that means fever, and also hepatosplenomegaly, enlargement of lymph nodes as well, and could be associated with what we call congenital infections at the same time. Some of those patients, they will develop a neurological impairment, and this is one of the causes of mental retardation, cytomegalovirus. So the cytomegalovirus is a typical herpes virus, double-stranded DNA genome, and the infected cells are large, and as you can see, cytomegalo virus, and this is almost pathognomonic compared with other herpes viruses. So this is typical of the cytomegalovirus infection. You can see the cells that they enlarge compared to other herpes viruses. Cytomegalovirus, enlargement of cells. They are pathognomonic of the CMV virus. So the cytomegalovirus then differs from other herpes simplex viruses and the varicella zoster in that it does not cause here skin lesions. This is really very important to know. But the cytomegalovirus is similar in its ability to establish latency or latent infections. The cytomegalovirus produces here a visceral type of disease, including a mononucleosis syndrome, and otherwise healthy patients or healthy persons in general. So here its major contribution to human misery is its high rate of congenital infections. Usually 1% of all infants, تقريبا 40,000 here in the United States per year, they are infected with this type of virus. Most of those infected are asymptomatic. However, some 20% may have a neurologic impairment. The cytomegalovirus also can important cause of morbidity and mortality, so associated with lots of suffering, especially in the immune compromised patients with either primary or in the secondary or in the reactivation types of the disease. So the epidemiology of this virus, we see that more than 50% of adults are infected with this virus. Almost 10 to 15% of children, usually they are infected. 1 to 2% here per year also increased the infectivity rate. Usually the infection is transmitted by close contact, including sexual intercourse. Around 85% of infants they secrete the virus, and 5 years even after birth they will continue secreting this virus. Almost 30% of infants in daycare centers here are infected. Then they transmit that into their parents. The latency is usually occurring in white blood cells, and in the presence here for donors. So in organ transplantation, they could infect this virus to others. Very important point to remember that the CD34 plus cells are usually the cells that are responsible for latency of this virus. The pathogenesis here, vascular, usually endothelium and leukocytes are usually the targets for these types of viruses. And inside they develop what we call inclusion bodies that you could see them here by the microscope. And also those viruses are associated with direct tissue damage in general. The immune response even against those viruses are associated with what we call immunological damage, so overproduction of antibodies against these viruses could be responsible for the tissue damage. Could be associated with cytolytic T cells activity, and they contribute to the pathology of this virus. Also, the endothelial cells also could be infected, and the endothelial cells are usually, and other sites could be responsible for latency of this virus. So the clinical manifestations of this virus, almost 100% of infants usually are asymptomatic, so they don't show any signs and symptoms of this virus. Very important point to remember that this virus could be associated with what we call a sensory nerve hearing loss. So the baby will be born deaf, and here those babies could be associated with what we call psychomotor mental retardation, or even both at the same time. 10 to 15% of those they could have both. And very important to know that it could be symptomatic, like those babies. They could have hepatosplenomegaly. Also, they could have what we call jaundice, and they could develop anemia, and they could develop here what we call thrombocytopenic purpura. And babies could develop what we call low birth weight. Babies, and they could develop microcephaly, as well as small skull, and also could develop here chorioretinitis and blindness associated with that. Especially here, if the infection occurs during the first trimester, then the damage is severe in those infants. So infants infected after delivery, usually there is no adverse outcomes here, unless the baby usually is premature or immune compromised. Then it's going to have a dramatic effect. Later, the patient could develop mononuclear like syndrome, and bone marrow transplantation could occur in 50%, could be associated with high mortality if they are infected with this virus. It's a major cause of blindness, very important to remember that, in AIDS patients. So to make the diagnosis, we have to detect specific antigens, or we could do a specific DNA detection in infected tissues here, or even the body fluids. We could isolate the virus in what we call the diploid fibroblastic cell lines at birth, or within here the first 2 weeks, 1 to 2 weeks after an infection. Positive later, positivity here later indicates perinatal types of infections. Usually the demonstration of seroconversion here into IgM indicates an acute type of infection on top of chronic. So when you here isolate a specific IgM antibodies, it indicates that this is an acute type of infection, and the infection, because the IgM does not cross the placenta, usually it's developed within here the baby. So here immunocompromised patients detection of viral antigens or the DNA, يعني يا إما the viral antigens or a specific DNA sequence indicates here viremia. So the drugs of choice that we use for a treatment, we can use the ganciclovir. It's very specific for this virus, and we could use immunoglobulins at the same time with these antiviral drugs, and we could use a combination of the ganciclovir and the immunoglobulins at the same time. And the significance of bone marrow transplantation, that here we could do an immune suppression in order for the transplantation to take place, and this makes the patient so vulnerable to be infected with this virus. Another drug we could use called foscarnet, and another drug we call it cidofovir also, and very important point to remember that in blood donors and here the ones the blood donors, they have to be seronegative here, because otherwise if they are infected, they will have a massive consequences related to that. So very important to control the sexual promiscuity, is where the virus could be transmitted. Till now, we don't have a vaccine against this virus. Those viruses, they could infect the retina, and we could here use the ophthalmoscope here to make the diagnosis of such types of lesions. So it's very important here to know that ophthalmoscopy can be used in the diagnosis of such types of viruses. A second virus that is associated here with a promiscuous type of sex is the human papilloma virus, and this virus can be transmitted also through sexual intercourse and sexual promiscuity. Human papilloma virus. And it's very important to know that this virus is considered also an oncovirus at the same time. So the human papilloma virus then is one of the oncoviruses that you should remember. The human papilloma virus are the most common sexually randomized infections in the United States and all over the world are naked, have a naked capsid, icosahedral, double stranded, circular DNA, like those of the herpes viruses, almost, that replicates in the nucleus of the infected cell by using host RNA polymerase for transcription. So they use RNA polymerase for transcription. And host DNA polymerase for genome replication. So these viruses, they use the DNA polymerase for the replication. More than 100 different serotypes are known of these viruses, of the human papilloma virus, have been identified in humans specimens. The genotypes are antigenically different, and groups of genocytes are associated with specific lesions and low risk of or high risk genotypes for cancer. So here when we talk about the human papilloma virus, it has to be associated with a specific serotype. The human papilloma viruses are transmitted through the skin to skin contact, so sexual intercourse, and through vaginal, anal, or oral type of sex. So any type of sexual activity could transmit these human papilloma viruses. Human papilloma viruses have been identified in common hand warts, تواليل, hand warts, plantar warts, for example, flat cutaneous warts of other skin areas. Human papilloma virus type 1 to 4 and 1, 2, 3, and 4, and 7, and 10. For example, in juvenile here, in juvenile laryngeal papillomas, so in the larynx. Here, human papilloma virus type 6 and 11, and in a variety of genital here hyperplastic epithelial lesions, including cervical or vulvar and penile here warts and papillomas. Human papilloma virus type 6, 11, 16, and 18, for example, are associated with this activity. In addition, they are associated with here pre-malignant type of conditions, cervical and intraepithelial neoplasia. And malignant disease, cervical cancer, human papilloma virus type 16 and 18, for example, lesions. Here comparable to those occurring in the cervix are now recognized in the anus, especially for those homosexuals. Very important to know, especially among men having sex with men, and homosexuals, and those who are infected by the HIV virus. Human papilloma virus type 6 and 11, they have low risk, are most common genotypes associated with genital infections, and cause benign condylomas and condylomata acuminata, we call that. Human papilloma virus type 16 and 18 are considered the high risk here genotypes because of their here potentially to cause malignant cancers, such as, for example, cervical cancer in women and oropharyngeal cancer here mainly in men. This is really a very important point to remember. While a majority of human papilloma virus associated infections are benign and cleared by the immune system over time. Some here progress to malignancies. For example, human papilloma virus can be detected by regular Pap smear here test, which is a screening here test for here for the cervical cancer, so they can screen for that cervical here recommended in women ages 21 to 65. So women, they should screen here for the human papilloma virus. 3 here recombinant, safe, effective, and long-term here protection vaccines, and they use those routinely, including the Cervarix. This is the first one that they use, and this is from human papilloma virus type 16 and 18 here, and the other one we call it the Gardasil 4, and this is formed of 4 viruses: human papilloma virus type 6, 11, 16, and 18, and the Gardasil 9, and this is formed of 9 different serotypes: human papilloma virus 6, 11, 16, 18, 31, 33, 65, and 52, as well as 58. Here they are licensed and recommended for routine immunization in 11 or 12 years old girls, they give it, and to boys and until age 17 years in the United States in particular. The Gardasil 9 is routinely used in the United States. So the human papilloma virus then uh, belongs to a family of viruses. We call them the papova viruses or papova viridae, and those are naked, double-stranded, circular DNA viruses of icosahedral symmetry. And those they develop like those of herpes viruses almost early genomes. We call them E1 to E8 for replication, and here a transformation, and then we have L1, L2, or late here structural proteins will develop. And more than 100 different serotypes are available. They form what we call epidermal papillomas and warts, papillomas and warts at Tawalil, like here oncoviruses. So these are viruses that are associated with cancer. Genome can integrate itself in the host chromosome, and here this is the mechanism of oncogenesis. Cervical, vulvar, and penile warts and papillomas, they are pre-malignant before the condition of malignancy, pre-malignant cervical and intra epithelial neoplasia. So these are very common viruses associated with malignancy. So this is an electron micrograph showing this human papilloma virus that almost looks like those of the herpes viruses, and you can see those out of the human warts wherever those are located, penile or vulvar types of warts, and you can see the human papilloma virus that is associated with such type of condition. So this table shows the different types of human papilloma viruses that are associated with human disease and associated with malignancies, and the different serotypes that we have talked about, serotype 1, 4, 7, and 10, and then here 6 and 11, 16 and 18, also here 31, 33, 45, 62, and 58, and you can see that they are associated with sexual types of transmission and the formation of warts, and especially at the genital organs, and how we can control those usually with vaccines or treatment by cautery, or sometimes even surgery and surgical excision of these types of warts. So these then viruses usually they are associated with genital location, and also here congenital warts as well in babies. There are about 30 different genotypes involved in the genitals. Also, we could see a single intercourse will be enough to cause these types of lesions in about 30% of cases. So the incidence rate is so high. more than here one sex partner, sexual promiscuity, like the other viruses that we have talked about. Also, serotype 6 and 11 are associated usually with benign here genital warts, cellular dysplasia, the pre-cancerous conditions, dysplasia. And also the perinatal here transmission and the laryngeal papillomas as well. Serotype 6, 18, 31, 45, and 56. Here we see those on the penis as well as the vulva, as well as in the cervix, mainly serotype 16, with malignancy associated with that. Also very important to know that it could be associated with anal neoplasia in the homosexuals. Very, very important point to remember. The pathogenesis of these types of viruses, usually they infect the squamous and columnar epithelium of the skin at the junction with the squamous and the columnar epithelium junction, and they are oncoviruses. Very important to remember that. The precancerous condition, they call it the epidermodysplasia vericiformis, and there is a genetic here susceptibility in serotype 5 and 8, and also the squamous cell carcinoma that is associated with that. Also the E6 serotype and the degradation of the P52 protein, which is, we call it the tumor suppressing gene. The E6 and the PRB here genome, we see that in retinoblastoma protein association. And also the E5 and the benign papillomas in general. Human papilloma virus and cervical cancer association is very important discovery in 2008, and they won the Nobel Prize here for this discovery. So we do have, in summary, more than 100 different genotypes of the human papilloma virus have been identified in humans specimens. The genotypes are antigenically different, and groups of genotypes are associated with specific lesions. The human papilloma viruses have been identified in plantar warts, flat, and in papillomatous warts of other skin areas, مثلا in juvenile laryngeal papillomas مثلا, and in a variety of genital hyperplastic epithelial lesions, including cervical, vulvar, and penile warts, and papillomatous. In addition, they are associated with pre-malignant here cervical intraepithelial here neoplasias and malignant diseases like cervical and oral cancer. Lesions comparable here to those occurring in the cervix are now recognized in the anus, especially in those, as we said, homosexuals, men having sex with men. So those that having the cervix, for example, now are rarely associated with tumors. Recognized in the anus, especially in those homosexuals that we have talked about. So the clinical manifestations of those types of viruses, the flat to deep plantar here warts. This is the usually the direct association with, and then the intra oral or the laryngeal lesions that could be seen, and the condylomata, acuminata. Those are the pre-malignant clinical conditions. They look like a cauliflower like lesions. They are pre-malignant. And also very important to remember the dysplasia to the intra-epithelial neoplasm here with serotype 16. This is very important to know. And the cervix and the anal orifice are the most common to be affected. Diagnosis usually by doing the pap smear and showing the perinuclear cytoplasmic here vacuolization, and then by doing the PCR and ELISA, here we can detect the antigens. Treatment, here the drug of choice that we could use here is the cytotoxic drug, podophyllin, and also the podophylitoxin, 5-fluorouracil, and trichloroacetic acid here, or by surgical removal of these lesions. Very important for the prevention is the sexual control or the sexual promiscuity. Here the use of condoms, very, very important, and pap smear for the routine and regular testing for these viruses. Vaccines, now we do have for the serotype 6, 11, 16, and 18, and they believe that those are very effective against these viruses. So these are the warts that could be precancerous, that they have to be identified and cauterized here, and you could see them in many different areas of the body, the perianal regions, or on the penile warts, and those usually are pre-malignant, as we said. Also, you could see those near the here the vagina or the perianal regions in the homosexuals at the same time. So the penile warts, the vaginal, vulvar, also are pre-malignant. So all of the sexual sites, they have to be checked. The perianal regions, as we said, and the warts that could be identified as pre-malignant, they have to be cauterized and removed. Very, very important. So in taking a biopsy and looking for those types of lesions, you can see here the pre-malignant conditions that is associated with having two nuclei, sometimes within the same cell, or this is what we call the dysplasia. And the dysplasia is the pre-malignant conditions that could be here pre-malignant. More of these dysplastic cells and the pre-malignant conditions that are associated with these types of warts, and the dysplasia that will be associated here with the pre-malignant conditions. So more pictures showing these pre-malignant conditions on the genital organs, the penis or the vulva, showing these types of conditions that could be associated with pre-malignant conditions, and then later here will develop into cervical cancer and malignancies. Again, these are the pre-malignant conditions, or the dysplastic cells and lesions that could be associated with the penile or the cervical type of cancer. More images showing the pre-malignant conditions, or the dysplastic lesions that has to be cauterized, otherwise they could be converted into malignant cells. So the treatment of these types of viruses, usually we use cytotoxic drugs like the podophyllin and the podophyllitoxin. We could use the 5-fluorouracil, as we said, and the trichloroacetic acid. Also, here we could use a systemic and local interferon alpha. They say that this is very effective. And also, we could use surgery here, and we could use laser here treatment, or even freezing with liquid nitrogen. And also, we have a condition that we could use for treatment. We call it the loop electrosurgical excision procedure, the EEP. And also we could use what we call conization, also known as cone biopsy. Here removes the abnormal cells and taking them out of the lesion. And also we could use the electrocautery and or radiation even into the lesions. And also now we do have very effective vaccines, as we said, for those types of viruses. Like we do have the bivalent vaccines. We call it the Cervarix, and this is the human papilloma virus type 16 and 18, and also the quadrivalent, 4 types vaccines, the Gardasil, human papilloma virus types 6, 11, 16, and 18, and we give that in 3 doses, and they believe that this is a very effective vaccine.